And next, I would like to welcome our panel member, Dr. Albert Garcia Romeo. He's going to tell me if I pronounced that correctly, and who is the assistant professor for psychiatry and behavioral services sciences at Johns Hopkins School of Medicine, and part of this Johns Hopkins Center for Psychedelic and Consciousness Research. And Dr. I am super charged up about this discussion today. It's something that I personally know nothing about, but I have read about the use of psychedelics as a treatment for various disorders. So we're really looking forward to this discussion. Before we dive into it, did I pronounce your name correctly? And if not, tell us how you pronounce it and tell us a little bit about yourself.
Yeah, absolutely. And so, first of all, yes, you did. My name is Albert Garcia Romeo. You can call me Al. I've been working here at Hopkins at the what we're now calling the Hopkins Center for Psychedelic and Consciousness Research for about 10 years. And when I finished my PhD back in 2012, I was really studying the impact of spiritual experiences on mental health because we found that for some people, having a spiritual or transcendent experiences can be really protective and beneficial factor for mental health. For others, it can sometimes lead to problems. And so that's really what I was studying during my PhD and doctoral program at the Institute of Transpersonal Psychology, which is in Palo Alto, California. But then I ran into this group here, including Roland Griffiths, Matt Johnson, Mary Casamano, and Bill Richards, and others. And they had been doing some pioneering work looking specifically at psilocybin, which is a naturally occurring psychedelic found in about 200 species of mushrooms. And they were really kind of reopening the book here because back during the 1950s and 60s, there was a robust program of research mainly looking at LSD, lysergic acid diethylamide, as a potential mental health treatment for things like palliative care and also for addictions. And some of that early research was very promising and showed some good results. But of course, a lot of the psychedelics, like LSD and others, really kind of got moved out of the lab somewhat and got adopted in popular counterculture of the day. The hippies and 1960s, it really took up, these substances like cannabis and psychedelics. And that also led to a lot of political backlash, mainly during the Nixon administration around 1970. You saw a big move to put all of these drugs on the Schedule One classification, which means they're basically risky and have no therapeutic benefit. And that really led to a lot of stigma that continued to the present day. But since about 2000, the lab here at Hopkins has been studying using psilocybin both in healthy participants just to understand the way that the drug works and what it can do. But then increasingly over the last decade or so, we've really been seeing more of a shift to look at psilocybin and other psychedelics as potential medications. And that has, again, kind of gone into a number of areas, but we've seen some very good results, preliminary results in people with major depression, which, as we all know, is a big problem. Substance use disorders or addictions, as we often call them, and also in cases of people with severe illness and related psychological distress. So one of our big studies that was published in 2016 was in cancer patients, and obviously they're often dealing with not just the cancer, but also depressed mood and anxiety that can come about as a result of that, and can really be um, detrimental to their quality of life. And so what we found in that study was that a single high dose of psilocybin was sufficient to have persisting antidepressant effects and reducing anxiety for these individuals for months afterwards. And that kind of led the way into the current work that I'm doing here with some of our colleagues, which is in a similar vein. And so there's a lot of comorbidity or overlap between people with Alzheimer's disease and related dementias who have understandably low mood or depression issues. And so we really wanted to know, um, is psilocybin something that could help that population and potentially improve their quality of life, reduce their depressive symptoms, and even more interesting, is there a possibility that this could have a positive impact on their cognitive function and memory? And so this is really the first step to determine the answers to those questions. Is that we're doing a small pilot study in 20 patients right now, where we're really recruiting people who have an early stage Alzheimer's disease diagnosis or mild cognitive impairment and some depressed mood, and putting them through a battery of treatment, which includes some preparatory counseling and 2 doses of psilocybin, and then really just tracking the outcomes. How is this affecting their mood? How is this affecting their mental functioning for several months afterwards? And that will give us at least a better idea of if there's some promise or potential here.
Great. So is this study still open? So if there's people in our audience that have loved ones who are in the stages of early Alzheimer's, can they participate?
Absolutely, and that has been a struggle, not just for our study, but I think for a lot of clinical research. I mean, in addition to all of the other disruptions we've seen since the beginning of COVID, it's been really hard to get people in the door. Understandably, there's a lot of concern about getting ill, and particularly in immunocompromised populations. But yes, we're actively recruiting and seeking individuals, preferably in the Baltimore area, because there
Yep.
are a number of in-person visits required. Though we are open to people who are able, and if they're willing to travel to be here for study visits. And yeah, we're looking right now for people who fit the bill who would be interested in joining the study.
Great. So, your colleague Bobby is on the call, and what I would say is, Bobby, drop in any contact details that our audience needs to know so that they could potentially participate. Now, I'd love to dive into this a little bit more, and this is what I don't really understand about this treatment is what it actually looks like. So, I'm going to confess, my I've never dropped acid or taken magic mushrooms, but my experience of it is from my college dorm and hearing the stories about somebody losing their mind on campus and what have you. And so I imagine others are may have a similar experience. So the idea of my mom, with early Alzheimer's using this, share with us what the treatment looks like, and maybe dispel some of the myth that's in the back of my mind on what of what the public might be thinking about
Absolutely, and I think that that makes a lot of sense. If you've only really seen this in sort of recreational settings or outside of a clinical setting, that is going to be a little bit different than what we're doing here. Um, what we have developed over the last 20 years, which has included dosing over 375 people and over 700 active dosing sessions with psilocybin here at our laboratory, um, is a safe protocol for doing this work. And I've actually built in extra safeguards for this population, which is individuals with the early stage Alzheimer's disease, meaning that we start with a lower than normal dose just to sort of ease into the treatment. But really, what we do is we had a few phases of this kind of a study, and so this begins with the screening phase. People come in, we do blood work, we take an EKG to get cardiovascular function, medical history and physical and examination, and we do mental health history to make sure that other than the problems that they're reporting currently with, the dementia or with the depression, they don't have anything else that would be considered a risk factor, that they would have a difficult response to the drug. And we have certain criteria that we look for, but things that would basically put them at higher risk of having problems. So that's, step one to get in the door. Once we've determined the person is physically healthy and psychologically stable to go through this type of a treatment, then we have a several weeks long preparatory phase. Usually about a month we would spend before we give anyone any drug at all. And during that month, we're developing a therapeutic relationship with the participant. We're learning about their life. We're trying to learn more about their symptoms. And we're also trying to build a trusting relationship so that by the time we actually get into the dosing sessions, they feel comfortable with the people that they're working with. And that's usually a team of two individuals, myself and a co-facilitator. Um, we will have all of these meetings. Some of them are virtual, but of course, dosing sessions are here in the lab. Here at the Johns Hopkins Bayview campus, we have physicians on site throughout the course of the drug dosing. But yeah, we do a lot of preparatory work specifically so that people have a sense for how they might respond to the drug or what to expect. And I think that goes a long way, in addition to the screening, to make sure that this is done, with optimal safety.
And I'm glad you brought that up because actually, Kevin, I can never pronounce his name correct. It's Kevin or Kevin. Kevin Peterson from Changing Aging says, Al, thank you. I'm so happy to meet you virtually. Can you talk about the approach you took screening and accepting participants in the study? Particularly, how do you determine what level of cognitive impairment was acceptable for a participant? I I think this is a hot topic of just defining that somebody has early Alzheimer's and not some other, symptomatic behavior.
Yeah, that's a great question. And, we had to do a sort of a tightrope, balancing act here because we wanted to be able to say that, yes, this person has a diagnosis of early stage Alzheimer's or they meet criteria for mild cognitive impairment. But we also don't want it to be a person who's in such an advanced stage of the disease progression that this could put them again at risk of having adverse effects of the drug. And so, in order to do that, we have very specific cutoff criteria, both using validated instruments like the MoCA or the Montreal uh, Cognitive Assessment, also using the mini mental state exam, and we have Dr. Paul Rosenberg, who's our geriatric neuropsychiatrist here at Hopkins, who basically is vetting all of the participants before they're admitted, and that also includes getting fully abstracted records, medical records from the participants or the candidates to ensure that we're not looking at something different like a frontotemporal dementia, some slightly different condition or symptom cluster that we mistaken for early Alzheimer's or MCI.
Great. Little technical question here on our broadcast, Albert. The Is there any way to adjust your mic volume, or can you move your mic closer to your mouth? We're getting a few comments on that, and of course, as we always get comments, I start getting excited and I start yelling into my microphone, so I'm like splitting everybody's eardrums. Um, uh, but
So I think I just
oh,
turned it up. So did that seem to help?
that's fantastic. That's a
Okay.
lot better. And then I'm going to try to calm down so that people aren't blown away by me. Everybody says thanks. That's great.
Yeah,
Okay.
sorry about that. I'm not highly technically proficient with these things here.
but but you know, so has psilocybin been approved for treatment of, of anything? And then okay, so it hasn't been quote unquote approved, but my question on this is, so let's say that you're using it as a treatment for depression. Is it one of these things that you do once a year, once a month, every week? Like, how do you sort of see this playing out as a treatment?
Right. That's something that's still up in the air because the majority of the work looking at psilocybin as a therapeutic has focused specifically on using psilocybin for people with major depression. So, how do we use this to help people with major depression? My colleague, Dr. Natalie Gukasian, and our team just published results from, I think, a week or two ago from a small study we did in patients with major depression. And what they found was that a short treatment that included two doses of psilocybin had antidepressant effects that lasted up to a year later. And so that's not true for everyone, but for the majority of the people in the study, they're not just getting reductions in their depressed mood that last a week or a month. Most of the people are still feeling better up to a year later. And so, we don't exactly know why that is, or who that's, who's going to respond and who isn't. But the early research that we're seeing right now, and again, particularly relating to depression, but also other conditions like addictions, we have seen what seems to be a long-lasting benefit that comes from just one or a few doses. And there is a likelihood that for some people, they may require more administrations of the drug over time, but we haven't figured that out yet. And there's more research that needs to be done to get there. However, I should note, the psilocybin is currently listed as what they call a breakthrough therapy by the FDA, meaning that they're doing what they can to facilitate research to get to either an approval state or not, depending on the data. And so there have been multiple large-scale studies underway using psilocybin as a treatment for major depression. And should the data continue to show what they have so far, the likelihood is that within 3 or 4 years, this will be an approved medical treatment for major depression and potentially for other types of conditions as well.
Great. Again, I don't want to dive too deep into the technical rabbit hole,
Yeah.
but what is it about the drug, and is the patient going through a sort of psychedelic experience the same way that what we've heard with LSD and mushroom trips? Are what is it about it that can change the way a person might be wired with that infrequent treatment?
Yeah, we're still determining that, and there seem to be a number of factors at play here. But I would say yes, there's been a lot of talk about microdosing or using very low doses repeatedly with psychedelics for mental health. So far, there's very limited data on that, most of which hasn't shown any real benefits. However, what we're doing is a sort of high dose model where we do use high doses of psilocybin here at the lab, where people are usually laying on a couch, listening to music. They're sitting with two facilitators that they've been working with throughout the process. And this is not just come into the lab one day, have a dosing session and go home and you're better. This is, like I said, we'll spend a month at least getting ready for that session. And we'll usually spend 1 to 2 months afterwards continuing to sort of dive into if there's been any insight or changes that people are noticing from the drug effects. But yeah, when they're under the influence, they're definitely having mood altering and mind altering effects, which include changes in thinking, changes in perception, changes in mood. And there seems to be some relationship between the experience that they have during the drug and the changes that they experience afterwards, in terms of certain types of experiences can lead to or seem to be associated with these ongoing psychological benefits. And so,
Great.
to give you a sort of really basic understanding, for some people, when they're under the influence, they're having experiences that they describe as either highly meaningful, insightful, or even spiritual in nature. And when they have those experiences, they can also feel like it was quite healing or helpful in terms of resolving things that may have been long held emotional baggage. Often we'll see people coming out of these experiences saying, I've forgiven this person who hurt me many years ago, or I realize that, it's time for me to make amends with this family member who I haven't spoken with for years, or, just, feeling as though they've been able to let go of things that have been bothering them for some time. Now, that's just one example of the type of
Yeah.
experience people describe. But that's really on the psychological end of the spectrum, that these experiences are kind of changing the way we think and almost maybe jostling loose places where we might be stuck mentally. Um, and then the other piece that's really fascinating then that we've only really started to understand over the last 10 years a little more is the way that biologically these drugs work. And I think the animal research in the last couple of years has been particularly exciting because what it's really showing is that one dose of a drug like psilocybin is literally causing new connections to form in key regions of the brain, like the prefrontal cortex, like the hippocampus. So these are important parts of the brain for memory and for thinking and decision making. And sure enough, scientists at Yale, scientists in California, have been studying the what they call neuroplastic effects of these drugs, and it seems to be that when animals are administered one dose of psychedelics like this, it sets off some sort of chain of events that creates a neuroplastic state. It can seem to facilitate learning and memory, and it can also seem to literally change the wiring of the brain, meaning that these new connections are forming and they don't just form and go away. But Alex Kwan at Yale recently published data showing that they found a month later those new connections are still there in the brain of these rodents that have been administered psilocybin. So that starts to give us understanding of the underpinning of the biology of why would this be good? Because there's things that can grow in the brain which is better or worse. We can think about tumors or even certain types of drugs that can cause addiction can kind of create new circuit formation that basically kind of keeps it coming back for more. That's not the case here. Really, what you're seeing is that the drug, a single administration, is causing growth in these key brain regions like the prefrontal cortex, which then would have potentially some beneficial effects in things like cognitive function, or decision making, like deciding not to use a drug, an addictive drug like smoking cigarettes or alcohol, for instance.
Wow, this is amazing. And yeah, as you were talking, I was sort of thinking about people that may have tried talk therapy and other treatments, but they're just still stuck, and having something that kind of forces you out of that being unstuck. And it sounds like this is in one of the directions that this is going. Okay, we got it always happens. We got tons of questions coming in. I
Sure.
see some that are in chat, so I'm going to kind of try to address the ones in chat, and then I'm going to jump over to the Q&A there. But so this is from Bob, who says, "I've taken magic mushrooms, grown in cow manure. Does your drug um, also use the mushrooms as part of the formula?" Yeah, it is. Is this a cocktail or a combination, or what, or is it the raw mushrooms that participants are taking?
So what we're using in the study is pure pharmaceutically synthesized psilocybin. So just like coffee beans have caffeine in them, it's an alkaloid that the plant creates naturally. And tobacco plant has nicotine, which is an alkaloid that the plant creates naturally. Psilocybin containing mushrooms create psilocybin. And if you look at psilocybin, the molecule itself, which these mushrooms just generate, it looks very much like serotonin, which is one of our major neurotransmitters. And so as a result, when that psilocybin is ingested, so if people eat those mushrooms, then that psilocybin binds to our serotonin receptors and creates all these changes in the brain. But what we use in the studies, mainly just for control of purity and dosage purposes, is somebody at a laboratory makes that molecule psilocybin, and then we have the pure crystalline powder or capsules that we then give to the participants. So that doesn't have all the other stuff in the mushrooms, because there are often other chemicals in there that we wouldn't know exactly how they're impacting. So we're using just one pure compound.
That's great. Great question, by the way, too. I was wondering the same thing. Let's see. Michael Smith says, "What are the pros and cons of the potential use of psilocybin versus typical SSRIs? Also, does the use of psychedelics have any impact on amyloid plaques, which is a major indicator of the onset of Alzheimer's?" If you can define SSRIs for those who aren't technically savvy on that.
Of course, yeah. So there's a lot of kind of accepted pharmacotherapies or medications for depression, and one of the first line treatments for that are SSRIs, which are selective serotonin reuptake inhibitors. Medications like Zoloft, like Prozac, which you've probably heard about. And so for some people, those work pretty well, meaning that they can take those medications daily, and over the course of a few weeks to months that they'll experience an improvement in their mood symptoms. And then if they're able to find a good dose, they can stay stable on that. And oftentimes people will stay on those drugs for months or years to try to keep their mood where they would like it to be. So there are also people for whom those drugs don't work, or those drugs stop working. And so in those cases, it's important for us to have new tools in the toolbox so that we can try to find other avenues to help those folks. And that's really what this type of study is about, is finding alternative methods. A lot of those SSRIs and other medications can also come along with unwanted side effects sometimes, things like sexual dysfunction. So things that are not that pleasant to have to experience. And so, even for people who they work for, they might prefer some other treatment options. Something like a course of talk therapy that includes a few doses of psilocybin, for instance, might be an attractive option, because although there are side effects like the mind altering and mood altering effects we talked about, those are actually pretty time limited, meaning that people come in to the lab around 8 or 9 in the morning, they have a dose of psilocybin, they sit with their facilitators until about 4 or 5 in the afternoon. And by the time they go home, usually they're going home with a loved one who's driving them. They feel more or less back to normal. And typically the next day, after they get a meal in them and a good night's rest, they feel fine. And so most of those side effects are confined to that short period.
Yeah, but I could see the value of diving into your experience with a therapist, social worker, psychiatrist, what have you, to maximize this this experience that you went through. So
Yeah, and that's what really sets us apart from sort of recreational use, because we go in trying to get a good understanding of the person and their symptoms and what's going on with them and sort of where they're at in their life. And then when we come out of the experience, we really spend a lot of time trying to make meaning out of it. What was it that you got? Was there any valuable lessons? Were there things that we can then leverage to make positive changes in behavior, or things that can be kind of, again, useful insights going forward? And so it is a therapeutic process. It's not all confined to the day of the drug session, but it's over the course of several weeks before and after.
okay, great. Man, lots of questions here. I'm gonna jump back. I was on the chat. I'm gonna jump over to the Q&A, but I promise we'll get through all these here. Someone asks, what is considered a high dose?
So typically the high dose that we use for most of our studies is in the range of about 30 milligrams. We had largely been using weight adjusted doses for the history of the studies we've been doing in the past, including the current study, meaning that a bigger guy like me is going to get a higher dose than somebody who's got a lower body weight. But typically the high dose range is 20, 30 or more milligrams of psilocybin. And in this study, what we're using is we're starting with kind of a more of a medium dose, is a 15 milligrams to start. And then if people do well with that, they have the option to go up to a higher dose, which is 25 milligrams, or to stay at the same low dose, 15 milligrams. And so we can really adjust that depending on how people respond to the drug. But that 25 milligram dose, which is the higher of the two, that's what's really being used right now in the big studies looking at psilocybin as an antidepressant. So that's why we're going up to that higher dose.
Okay, great. Brett Reed has an interesting question. How can you expel or minimize any expectancy effect the patient may have? So I'm assuming that it's sort of, hey, mom, you're going, you start going through this counseling to lead up to this. I could see where that expectancy could be kind of nervous. I might be kind of nervous if I was going through treatment like this.
Yeah, no, and expectancy effects has been a huge issue in psychedelic clinical research, mainly because there's not a good way to do placebo-controlled studies here. So, for instance, if I bring you in and I put you in a room and you lay on the couch for 8 hours and you had a placebo, it takes about 30 to 45 minutes before most people get wise and say, okay, I'm not on anything or I don't feel anything. Whereas if I give you a very high dose of psilocybin, like 25 milligrams, chances are you're going to notice it, we'll notice it, and then we'll, respond accordingly. And so even, I've been in meetings this week with the FDA trying to talk to them about how do we study this in a way that's, dealing with these types of expectancy effects. And, the other kind of issue that we've been wrapping our heads around is when we do this work with people, how do we prepare them for that? And so, really, the best way we've found so far, besides building a good working relationship, is to just kind of give them the gamut of, we've been doing this with hundreds of people for a couple of decades. Here's what people have gone through, and here's what they've told us. And you may have some of these types of experiences, or you may have something completely different, which we've never seen before. In which case, we'll have to add that in, to the list for the next person who gets the preparation.
Excellent. And then let's see, Donna Blackwell says, what are some of the downsides and negative effects? And yeah, it's sort of, I imagine you get this question all the time in terms of if what's a negative side effect that could happen to my mom.
Yeah, sure. The main ones, there's a few that we need to keep a track of. One of them is cardiovascular effects. So we know that these drugs can boost your blood pressure, boost your heart rate, and so as a result, if people have certain heart conditions or they may be prone to things like strokes, then we wouldn't want to give them a high dose of this drug because it could cause issues. So that's why we do an EKG beforehand and we do a thorough medical workup. The other thing that we see is that people can have very challenging experiences where they have a lot of anxiety, fear, even feelings like paranoia or panic. And that happens in about 20 to 30% of the high dose sessions that we do here. But thankfully, you can think of it almost like going to a horror movie. People might be very scared for the duration, but we're there to keep them safe and then kind of talk them through that process. And once they're done with that, usually it does not lead to any sort of lasting problems. It's more of just that was scary or that was challenging. I was very anxious, and so we do our best to prepare people for that. But when it happens, usually what we do is we spend a lot of time, doing things like hand holding, breathing exercises, just trying to orient people to the fact that what they're going through is temporary and that will pass. And for most people, that's more than enough to get them through and to sort of move them on to the next part of the experience. So it's not like you're going to be terrified for 6 hours, but it may be for an hour where people are feeling overwhelmed, and we kind of help them move through that, and then they move on to another part of the day.
Yeah, and it would be, it'd be really interesting to know when people are in that sort of anxious and terrorized state, for lack of a better term, that how much is that them getting through a difficult challenge that they're stuck on, and how much of it is just I'm not of my right mind. My the former, getting unstuck is challenging for all of us, and it's sort of being forced into it with this treatment. I could see where that could be that could be kind of a challenging part of this treatment, but but very effective. Um,
Absolutely. And just to put that into perspective, usually when people have these difficult experiences, they do come out and say, even though that was unpleasant during the actual drug effects, it was also insightful. It was also useful. I learned something or I got something out of that.
mhm.
I almost think of it like doing something really difficult, like running a marathon or cleaning out your garage. When you're doing it, it's tough, but when it's done, you feel better about it. And so
Yeah.
that's how we try to create a safe container for those difficult experiences, so that they can also lead to ongoing benefits after the fact.
Yep, no, that's great. Let's see. Rebecca Priest says, "Thanks for sharing your work. Are there any prospective or current studies underway working with individuals who have developmental or intellectual disabilities? How about PTSD? Building a therapeutic relationship guide role here could be more challenging. Yeah, especially if it was a intellectual disability."
Yeah, so we've not done or planned any work in that population, people with developmental disorders or sort of intellectual disabilities, but that would be very challenging for many reasons. But they're considered, it would be considered in many cases a vulnerable population. There can be issues around consent, which is actually something that we grappled with too for this study. How do we make sure that people who are joining understand what they're getting into and that they're on board? So no, there's no work that I know of with specifically those conditions, though there has been some work in folks with autism spectrum disorder, and so it's maybe a little bit related, mainly using MDMA, but other types of psychedelics as well. There's some interest there because these drugs can also affect our social cognition. And in terms of PTSD, yes, that is a difficult, population, mainly because, like you said, it can be very challenging to establish a good therapeutic rapport and a sense of trust in people that have been traumatized. But we do have a study in the planning phase right now that we hope to start later this year using psilocybin assisted treatment for post-traumatic stress disorder. And so we'll have to find out more once we're able to run that study, whether it's helpful or not.
Okay, great. I'm going to drop into chat here a suggested article from Caven Peterson on on a study showing some results, and then Shoshana Schomburg, who I recently reconnected with, awesome occupational therapist, is suggesting. She says, "Can you suggest books and published studies?" I'm reading "How to Change Your Mind" by Michael Pollan.
Mhm.
I'll drop that into chat for everybody. But Shoshana also says, "Are you comparing studies with other modalities that calm the limbic system and sensory systems with immediate and long-term results?" So she had a two-part question: readings on this topic, and then asking about the limbic and sensory systems.
Yeah, so there's a lot of readings, and nowadays it's almost hard to keep up with. And I will go ahead and post in here in the chat just a link just to start to our website where all of the papers that we publish are there. And that's, I couldn't tell you how many, probably a couple hundred papers we published in the last 20 years on this. Um, but in addition to Michael Pollan's book, which I think is a great primer, my colleague Dr. Bill Richards has written an excellent book, which is called. Let me find that real quick here. But, sorry, I'm trying to multitask.
Yeah, it's
Sacred
very
knowledge. There
difficult
you go.
to talk and type
And
in the
type
chat
and
at the same
read.
time.
Yeah.
Yeah, exactly.
Oh, I'm sorry. I put the wrong link in there. Here is the list to our publications. And then this should have links to all of those publications. But yeah, that's right. Sacred Knowledge by Bill Richards is a great primer for this work as well. Really more focusing on the spiritual religious orientation around this work. But he's a scholar and has been working in the field for decades, and so I think his book is really a nice place to look as well. And yeah, I mean, really, you can't throw a stone without finding stuff online these days about psychedelics and mental health. So, I think the main thing is just to look to make sure that they're credible sources and not snake oil salesmen, because there's a little bit of both out there these days.
Deb Merrimer has a good question, and you're probably asking this for a friend, Deb. If a person had a bad experience with psychedelics back in the day, would this automatically exclude them from participating in research like this?
Not necessarily. And, as I said, there's a big difference between doing it in one of our session rooms here in a hospital with a doctor after, multiple weeks of preparation and using a very specific dosage that we've spent, years studying, as opposed to taking something that somebody got on the street, They don't know how
Exactly.
much they took. They don't really know what was in it, perhaps. And so, of course, it would be a consideration. We would ask about that, and if there were certain red flags, specifically developing psychotic-like symptoms afterwards, after that bad experience, then likely we wouldn't go forward. But I don't think it would necessarily be an automatic exclusionary thing for us.
Okay, great. Brett asks, are there any regenerative effects that you've found so far that you can talk about?
So we were just in the very early stages of this study. As I mentioned, COVID has sort of knocked us offline for a while now. But so far, we've only run 3 individuals through the study. Everybody's doing well, and we've had 2 dosing sessions per participant with no problems. But in terms of that sort of neuroregenerative stuff, it's much more difficult to study in humans. In animals, usually what you do is you give them the drug, you look at the brain before and after, and oftentimes, unfortunately, the animals are euthanized, so you can cut open the brains and actually do work to see what's changing in here. And of course, we can't do that type of thing in humans, but what we have done is just looking at monitoring brain activity from the outside using tools like fMRI. And what my colleague, Dr. Fred Barrett, for instance, has found is that when you take a healthy person and you give them a high dose of psilocybin, it's changing the pattern of brain functioning in, again, these key hub regions, not just the day after, but up to a month later. You're seeing shifts in that person's both brain function as well as their emotional state, so that they're experiencing more positive emotions, and that's correlated with things like reduced amygdala um, connectivity to other regions. And so again, we're seeing that it has some uh, effects on the way that the brain is functioning, not just when people are under the influence, but for some time afterwards. And that's correlated with some of these benefits like improved mood. But in terms of actually looking at what's happening in terms of those connections, that's been pretty much only done in animals because of limitations we have.
Great. And Gary Graham has a question specifically on the study, and again, this is to remind people, especially if you arrived late, that Johns Hopkins is conducting a study of this treatment, and you can figure out if you qualify, what have you. But Gary says, I live in Colorado. What are the logistics of me being able to participate, short of moving there for several weeks?
Yeah, so that's a little bit difficult. We have had some people try to join the study from further away, but basically it involves probably a series of, I think, about 6 in-person visits over the course of about 6 months. So usually people would come in for an initial screening visit to do the EKG, blood work, and all that stuff to make sure they're eligible. And if so, we've been able to do a lot of the preparatory stuff virtually, like we're doing our meeting today. But of course, the drug dosing sessions people have to come back for. And then for follow-up meetings, we're often doing in-person batteries of tests that need to be done here at the lab. And so people end up having to come back a few weeks and then months after the dosing session so we can follow that up. So of course, that does present challenges for people who are outside of this sort of immediate mid-Atlantic area.
Mm-hmm. Shoshana asks, do you use SPECT brain scans or EEG to compare before and after results, and then monthly periodically after that? Yeah, that be curious. Yeah.
So not in this study, we're not using any SPECT or EEG, but we are doing other work in other populations using EEG before and after, not SPECT. It's not something that we're using right now. But yeah, EEG is a great tool because it's non-invasive and we're able to kind of look at what the brain is doing. But yeah, we're mainly looking at things like mood and working memory and quality of life. And so a lot of these are sort of softer assessments that are looking at how the person is experiencing their day-to-day life.
Okay. And then Brett Reed says, in terms of using psilocybin for treatment of depression, would you continue to prescribe SSRIs along with other treatment between the scheduled um, psilocybin treatments?
Great question. So right now, for our studies that we use psilocybin, mainly we are asking that people not be on those types of drugs, either SSRIs or MAOIs, really anything that's going to be altering your serotonergic system, because there's a possibility for interaction, and we're not really sure how that's going to work. And so we just would rather not have people who are on one drug that's impacting your serotonin system and give them another one for safety reasons. There's been some preliminary studies showing that it doesn't seem to be dangerous for people on SSRIs to have a psychedelic experience, but that it also could lead to changes in the way that the psilocybin, for instance, is processed. So as a result, the people who are joining the studies that we're doing are almost always not on one of those types of medications like SSRIs.
Great. Let's see. Kelly, you had mentioned music in sort of the in part of the experience, and she asks, do you or will you use the same music selections with subjects with Alzheimer's disease?
Yeah,
I'm
so we published a little bit about this. We've been using more or less a standard playlist for a long while now that has been developed by music therapists specifically for psychedelic sessions. There's other really interesting work looking at tailoring playlists specifically for older populations or people with dementia as well. But we're not doing that here. We're using our standard playlist, which is mostly Western classical music and a little bit of world music like Indian classical music and sitar and stuff, which plays throughout the day. And then we also invite participants or their loved ones to create short playlists that we can also intersperse into the actual drug dosing day. And so if they have music that they want to hear, then they're welcome to bring that. And that can be, of course, things that are, old favorites of theirs, or songs that are particularly meaningful, a song that I danced to at a wedding with my spouse or something like that. And that can always be nice to have in the sessions as well.
great. Okay, let's see. And we're going to be wrapping up here in the next 5 minutes or so. Linda Jeffers says, I have long haul COVID symptoms that are similar to early Alzheimer's. Also, I have a family history of Alzheimer's. Would this treatment help with COVID brain fog fatigue as well?
We don't know. So I just can't give you any response. Reason being, it hasn't been studied. Obviously, COVID's a relatively recent phenomenon, and I don't think anybody has specifically done a study in that area. Although anecdotally, I'm sure if you go search on Google or online, you're going to find people who say that they're trying things like that, and maybe they are or are not finding good benefits. So it's an open question at this point.
Great. And then Caven says, Dr. Garcia, is your center considering doing research on the benefit of psilocybin in helping family members of people living with dementia cope with their sense of loss and trauma? Much of the suffering people living with dementia experience is caused by family members' difficulty in coping with the changes they are experiencing. These negative interactions are often described as causing more suffering than the actual symptoms. Are really great question, comment, and commentary on the challenges of dealing with dementia.
Yes, and that's a really important area that we're trying to study, mainly because everybody that comes into the study has what we call a community observer, which is a spouse or a family member, a close friend who joins the study with them. And that person is going to be also filling out questionnaires, doing interviews and letting us know what their experience is like going through the process. Now, of course, we're giving psilocybin to the patient who's got the early stage Alzheimer's diagnosis, but we also want to understand if it's improving their symptoms and is making their life a little better, how is that impacting, for instance, their loved ones and the people who live with them? And so that's what we're studying as part of this research. We're doing these questionnaires and surveys and interviews to see, has this had a positive impact or neutral or even a negative impact on your life experience with this individual. I think the other piece that could kind of be a step further would be to say, if people are dealing with the difficulty of caring for a loved one with one of these really challenging conditions, could a psilocybin session be helpful for them? That's sort of beyond the scope of what we're looking at right now, but it's certainly, I think a feasible question.
And one of our attendees commented that they had brain fog from COVID and used cannabis edibles. The treatment of that seemed to help. So just for that person in the audience that was asking about that question, and out of curiosity, like something like cannabis, and I think you referenced MDMA or other drugs that were more less pharmaceutical, more natural drugs that are out there. Does Hopkins have does Hopkins have a division that's working on cannabis treatments and things of that nature?
Yep. Yeah. So our laboratory actually, and Dr. Paul Rosenberg, who's one of my collaborators on this study, I initially approached him because he was studying cannabinoids in dementia patients and trying to understand whether things like THC or some of the some of the compounds found in plant cannabis could be useful for patients either with Alzheimer's and related dementias or other medical conditions. So downstairs, our lab has a unit that uses and is studying cannabis, including using things like oral administration of cannabis edibles, and really trying to get at can this be useful for treatment purposes? Because obviously it's out there and people are using it, but it hasn't been well studied because of a lot of regulatory restrictions that are in place.
Yeah, and the way that you describe how you administer psilocybin to me, I mean, it just gives me way more confidence if I had a loved one or myself needed treatment like this at some point. And like you said, with a lot of these drugs, there's people out there self-medicating. They may be seeing benefits, but not doing it under um, a structure is can you could see where that could be dangerous.
Sure, sure. And the structure, I think, again, is a big part of why why we've been able to do this safely with so many people for so long now. So,
Mhm. Okay, I'm going to make this our last question, and I know whenever I say that, more questions come in, but we got to get the doctor back to his research. And
and I'll put my email to you in this chat box here, and that way, if
excellent,
people have questions, you can just shoot me an email. I'll be happy to try to point you in the right direction.
I
So.
love it. And so Shoshana says, do you survey family members, etc., as well as the self-reporting to document results?
Yep,
I'm
and as
curious.
I was just saying, this is actually pretty common when you're studying Alzheimer's and related disorders because sometimes because of the memory impairment, a person may not have a good recall of if they had had mood problems or anxiety, and so or what types of symptoms they're experiencing, and so yep, absolutely. Like I said, every participant in this study has this community observer that's also along for the ride, if you will, and so we're in regular contact with them. So far, it's been children or spouses of the primary participants, and they tell us too. Here's what I've seen. My spouse is doing this, or my dad has been more upbeat, or whatever it is that they report.
This is great. Well, thank you so much for your time today. This has really been eye-opening for me personally, and I hope the audience feels the same way. I have a much different uh, way of thinking about this type of treatment than I did before we started this conversation, which is what we want to have happen on these discussions. I thank you for all your insight and this research that you and your colleagues at Johns Hopkins are doing. But once again, the star of the show today is this audience that we have that just has so many thought-provoking resources that they're sharing and great questions. This is fantastic. I hope you enjoyed your time with us today,
Yeah, Steve,
Doctor.
it's a real pleasure meeting you and chatting with you all and getting all these great questions. I put our lab website one more time there, but that's a great place to look. I mean, there's, video clips from 60 Minutes where they've interviewed our participants and all sorts of, publications and links to all of the studies that we're doing. So please feel free to reach out if you have any other questions. But, thank you all. And yeah, absolutely don't feel shy about reaching out. So
You bet. Okay, talk to you soon.
have a good weekend.